So welcome everybody. So today we are going to share the experiences that our colleagues are experiencing in the periphery of Nepal during COVID-19. So we all know that our panelist is from east to west of Nepal. So our panelist is from western region to the eastern region of Nepal. So we are covering about roughly about 3 million people. We are and about 30 million people. Sorry, and about 1,47,560 16 kilometers of experiences. So so we know that the COVID, it has affected the world more than roughly about year about this many people are confirmed cases and more than 4,62,000 dead till now. In Nepal, we have the population is roughly about 3 million and total tests done till yet is roughly about more plus 4 lakhs, in which PCR is about 1,61,000 and RDT is this. And confirmed cases till yesterday, this is the data of yesterday, and I think that today the data is more than about 8,600 and death is 22 till yesterday. The patient with COVID-19, they come with a lot of symptoms, and the symptoms roughly they appear from 2 days to 14 days of exposure. We all know the symptoms of fever, cough, shortness of breath, chills, muscle pain, and headache. They are explored before coming to us. But the symptoms of sore throat and loss of the taste and a smell are less commonly explored by our the people who are sitting in the fever clinic. So, and most of the time, the people, they don't say that they have a loss of taste or lot of and the loss of smell. They come with another complaint of headache. They come with a complaint of something earache, but those patients may also have a change in taste or change in smell. So, as being a ENT people, which we are much more vulnerable to other things also. So we are much more vulnerable people. And disease peak. According to the study done by Indian Council for Medical Research, it has estimated that coronavirus peak, that COVID-19 peak, will come in India in mid-November. So till yet, the circumstances in India and Nepal are more or less the same. So we also haven't seen our peak. So lockdown, it has only shifted the peak of pandemic from estimated 34 days to 76 days. So it has only shifted. Why did the lockdown was done? Allowing the time for healthcare systems to shore up with all the resources and infrastructure. We are already easing our lockdown. So that doesn't mean we have passed our peak. We are still to see our peak. So by the end of this month, that is Asar, we are expected to have our cases reaching toward 40,000. So we are expected to reach peak by the end of Asar or by the mid of Shravan. And nowadays we are getting our colleagues getting exposed to the disease. Yesterday there was a report saying that a hospital director from Rapti and the nursing in charges were corona positive. So we should be very careful. So death. So in India, 31 doctors and 3 nurses had already died due to COVID. And in Russia, the number of the death of ENT of the doctors from COVID is about 489. It is a news of yesterday. So we healthcare worker or we being a doctors are also commonly affected, and the death rate is not that uncommon. This was a study done a bit ago. It was done in April, which was where 192 healthcare workers or doctors who died of corona in this country called Italy, Iran, China, Philippines, United States, and Indonesia. Among that, the average age of doctors was about 63.4, and male doctors were 90% affected and female doctors were 10% affected. See, our ENT doctors were also the 4% of those who died due to corona during this pandemic in April. After the corona outbreak, WHO it provided some responsibility or guidelines to a healthcare worker for occupational safety and the safety of others also. In gist, what it says is that it is our responsibility not only to treat the disease but equally important to safeguard others. We cannot afford to transmit disease from one patient to another patient knowingly or unknowingly. Similarly, the protecting our staff and other patients is equally important. So we can't afford to be careless. And medical ethics says that negligence is not accepted in pandemic. So why we should be more careful? There was a news that stating in Pokhara corona ko कहर डुरुवा डाक्टरबाट कोरोना समुदायमा फैलिने. So people are started blaming the healthcare worker as a super spreader of a disease. So we should consider this. Today or tomorrow we are going to get this blame. So we should plan to minimize the risks before providing any service. Either it is indoor service, outdoor service, or it is an operation. So Society of Otolaryngology of Nepal, a few months ago, we have made some guidelines which was approved by full house of Nepal Medical Council and endorsed it. So we provided some safety guidelines so that we ourselves could be protected, our healthcare workers will also be protected, and our patient will also be protected. Similarly, we are also working to on something so we are working on this. So we are working on something so that our colleagues will be protected. So we are planning. So we had planned to prepare some drapes. So this is a drape that we are using nowadays, and we are also modifying it every day so that it will be better. So after it is, so we think that it is appropriate to use and it works properly. So we are going to share this with all our SOL members so that if anybody wants this, we can provide them. So this is a drape that we are using nowadays. So I'm using this drape to do a dilatation of an 8-month-old child who was having subglottic stenosis. So for laryngology and this thing, this can be properly used, I guess. So we are also trying something on our clinics also. So in the clinic, what we are using is that there is a fan behind the doctor, and which pushes the ear, and the patient nowadays sits in front of the just on the door. And these patients are not supposed to sit here. They are normally advised to sit away from in front of the door. And we are using this acrylic film. Which is just like a glass, which is in front of the, which is in between the patient and doctors, and we can just pass a light through this and see the patient. So, so that because every time it is not convenient or not possible to use a face shield also while seeing the patient. So we are trying to this with this also. So and I'm like to share something of some news that we see. So a few days ago, means a month to 1.5 months ago, we used to see a lot of people queuing for something. And when we went there and we talked to the people, why are you here in such a long queue? Then they were in a long queue for this medicine, which was supposed to prevent the patient from a coronavirus, which was a homeopathic RC Nicum album, which is now freely distributed by a homeopathic association. And we went to do a study. Does this prevent corona? So Department of Ayurveda and Alternative Medicine in Nepal has approved this. But so we thought how this came into the market. So initially it came to the market when Ayush, so ministry advocated it in India to use this for the treatment of the corona. So then we talked to our expert in Nepal. So our expert, they told that herbal plants or minerals based medicine can increase the immunity to fight a corona in long run. But it is not advisable to distribute this medicine as a proven cure of the COVID-19. So in this COVID era, we cannot trust anyone. We cannot trust anyone. So we see there are a lot of news of fake news coming from a very big people working in the United States where the research is based on a fake data. So we cannot trust anyone. So what we can trust is only by giving our services, by working on all those things which can give a good safety environment for our patient, which can give a proper safety environment for our healthcare worker, and which can also protect us. So today we are here so that our panelists can share their experiences, so that we can learn from each other, so that we can do a safe practice. So I'd like to request Dr. Dheeraj to share his slides and just share your experiences, how you are dealing with COVID, so what are your experiences in the phase of COVID era in eastern part of Nepal?
So, good evening. So, I would like to take this platform to thank the SOL for giving me the opportunity to give my views, and at the same time, I would like to inform everyone about the inauguration of Purvanchal Cancer Hospital in the eastern part of the country in Province 1. So, we have been giving a full service of the cancer treatment here, including the radiation and the cancer surgeries. So, considering the ENT practice during COVID in the eastern region, basically in the Japa and the Birtamod area. So during the month of the Chaitra, during the month of Chaitra, we shut down all the OPD services. Only the emergency services were only given in the our ENT department. So basically, the head and neck oncologic surgery, aerodigestive tract emergency, trauma. So all the elective surgeries were postponed. Endoscopy and the routine OPD cases were not seen at that time. So what was done during that time was we already started running our fever clinic, and all the patient has to go through the fever clinic even in the emergency situation who has to come. And at least that time the PPE was not so easily available, so somehow we managed to have some N95 mask and some locally made face shield at that time. So we don't have the opportunity of having face shield that time, and we maintain the social distancing that time at least of 1 meter, and only the emergency cases, mostly like epistaxis, aerodigestive tract emergencies, and head and neck oncology cases, and the trauma cases were only seen that time. So that run through the month of Chaitra and Baishak, and from the 1st of Jaish, as many of the places in the Kathmandu as well as in Nepal has decided to open the OPD services, so we also started to have it open. So what was done that time was some modification was done to run the OPD, considering the limitation of the duty hours, and what we did was the as previously we have been doing the fever clinic, same all the patients were to be screened through the fever clinic, and we maintain a proper social distancing. And as you can see in the videos and the pictures here, like this is our OPD in the front of the OPDs. We have been keeping a distance of at least of a 1 meter between the patients, and we also limited the number of OPD patients so that there won't be a much chaos that time. And same time, considering our protective wear, so as you can see in the picture, I'm wearing a face shield and N95 mask and with a apron, and same time I'm having a scrub suit wear. So this will help not to protect only myself but from my to my family as well. So when I go to the hospital, I will change this scrub suit, and when I go out, I will again change this to my normal dress. So it will help to prevent not me but also my family members as well. So this was done that time, and this is another picture me seeing a patient. So although it was it's very much near to the patient, but still I'm wearing a face shield, so at least that will help to prevent me from some aerosol generating procedure. And only from the month of just we started doing our OPD endoscopy procedures, and that also only in the limited patients. We have been doing this till now as well, explaining them the risks of the aerosol generating procedure and what can it can be harmful not only to them but as to us as well. So we have been able to explain them well, and have been doing only in the emergency cases and required cases, not in all like LPR or those things. And you can see this is my health worker. He is doing a I have given him a full PPE set as well as a face shield, and I let him do all the NPL, and he is good in doing those as well. So not everyone, because PPE has to be worn by everyone. So it's like we cannot afford to have one suit every day. So he always do this procedure by himself, and we also be there. And during this period, so considering the emergency surgeries, so we have been doing is the mostly of aerodigestive tract like tracheostomy or foreign bodies. And as the cancer hospital has been also started in our center, so we have been getting a lots of cancer patients from the province 1, 2, and from all over the country. So pretty good number of cancer surgery has been going on, and we have been doing this. And so we have to do this considering as a semi-emergency, and the trauma and the epistaxis, and considering the safety only in the suspected cases, we have been able or have been fortunately able to consult with the government, and it's little difficult to get RDT or PCR done in all the cases here because it's not so easily available, and it's a private hospital as well, so there is some pressure from the management as well as there's this test can, if we do it regularly in all the patient, if somehow it came up positive, then all the hospital might have to be shut down. So there are some other issues as well, but uh, saying that still we are able to after going through the fever clinic only in the suspected cases or when they are from the high that red zone areas, we are being able to do this RDT, and mostly not RDT but PCR mostly in the suspected cases before doing the emergency procedure. So this is me doing some of the emergency procedure in the OT and with my nurses. So I'm wearing a full PPE, and they are also giving provided N95 masks and face shield, as you can see in the pictures. So how about my support from the hospital? So it is a private hospital, so it's not so easy to negotiate with them. So, but still, we are fortunate enough to give N95 masks once a week to each of the staffs of the hospital, and face shield at least once at the beginning. And it has considering the economic burden, so it has a big, I think, impact on a personal growth of each of the doctor and the health personnel in Nepal. So we can see that I have written here initially in the month of the Chaitra and the Baishak, even the salary was reduced to a daily wages. Like only the one who will be coming to the hospital will be given around 50% or sometimes even less in the when the income was low. But now eventually it has this, when the services has been now growing a little smoothly, so the salary now is like 50 to 70%. So we have been able to negotiate at least with that much of amount. So considering our elective surgeries, so planning like
Okay, so I think Dr. Dheeraj was almost done. So can I request Dr. Ashok to share his experience?
Good evening, everyone. I am based at the southern part of Nepal, that is Province 7. And I'd like to thank SOL Nepal and Earth Science for providing me this opportunity to share my experience. And this is the City Provincial Hospital where I work, and this is my private clinic. And since the lockdown was started, our hospital, City Hospital, was designated as a COVID hospital. So all the OPD services were closed initially, but emergency inpatient and emergency operation were continued throughout the lockdown period as well. And the OPD restarted in our hospital around 20th of Baishak, and we simultaneously started the clinic as well. And it's been almost 1.5 months since we started our OPD also. And now I'm going to share my experience with how I managed my clinic during in this COVID era. And first of all, we minimized the duty hours of the staff to prevent them from exposures. We divided them into 2 groups, and one group will come in the morning shift and another will in the evening. We try to maintain the social distance among the patients, and mask is made compulsory for the patient. And the screening is most important, I think. One of the staff measures the temperature and also takes the relevant history like fever, shortness of breath, cough, as well as travel history also. In the OPD, I changed my usual OPD room. I changed this model for a well-ventilated room. And in the OPD setup, I try to keep the fan behind me as well as in between the me and the patient, so that it can divert the flow of air from the patient, and no visitors were allowed as possible, and masks made compulsory. Initially, we tried to examine the patient wearing full gear PPE, but due to this hot weather, it was intolerable. So now I use cotton gown, face shield, mask, covers, and gloves when examining the patients. And for ear examination, I use this video system with rigid endoscope. It helps to maintain the distance with the patient compared to the otoscope. We can even do suctioning with this system, and it can also be used to examine the nose, but better not to take it deep inside the nose if it might induce sneezing. And for throat examination, I'm not using any kind of shield between the patients. I use face shield and N95 mask as well as goggles, and I avoid putting anything inside the patient mouth, like temperature, as far as possible. And we have to repeatedly counsel the patient not to cough or sneeze, however good it may sound, but we have to repeatedly counsel the patient because they have tendency to show their cough and sneeze to the doctor when they come into OPD. And the OPD procedures, the suction clearance and syringing, we are doing when absolutely necessary, but with the same precautions, no extra precautions. And regarding endoscopy, I have tried to maintain a well-ventilated room for endoscopy and trying to avoid unnecessary endoscopies. And any modification, masks, I try to use mask with a hole for the nose, but I found that bit uncomfortable, maybe due to learning curve. So now the mask only covers the mouth of the patient and nose remains free. What I try to maintain is to stand behind the patient as much as possible. I don't stand in front of the patient, so that even if they confuse, they sneeze, it will not come directly onto me. And during the procedure, we have to repeatedly tell the patient not to cough or sneeze, repeatedly remind them. And reporting, giving printed report is also minimized, avoided to minimize the indoor time. I tell the patients, I tell my assistant to record the video on the mobile. Now, regarding the government hospital, this is our OPD setup. Now, all the OPD, we have moved OPD to outdoors. We don't examine the patients in the OPD room. We have made OPD in the lobby. This is our fever clinic. This is our screening room, and these are the OPD in the lobby. And this is our ENT OPD, temporary ENT OPD. Due to hot weather, sometimes we use gowns, sometimes we don't. But face masks and face shields are absolutely necessary. And regarding surgeries, elective surgeries are postponed due to emergency surgery. Most of the cases are abscess, foreign bodies, and epistaxis. Regarding PCR, we have a PCR machine in our hospital, so it's an advantage for us. But the hospital is overwhelmed with PCR samples due to high patient load in quarantines. So it's a bit difficult, the manpower is less. So doing PCR for every patient is not practically feasible. So we try to do PCR for high risk cases, but I personally use PPE for low risk cases as well, doing an ENT procedure. But some other departments even don't use PPE. They are doing simple gowns and masks. And during surgeries, we try to maintain the minimum staff in the OT room. Only the person wearing the PPE does the surgery. After all the preparations are made, I tell sisters and anesthetists to stay a bit away to minimize the exposure. And for regarding personal protective equipments, N95 mask, hospital provides us few masks, not every day, but a few around 10 or 12 every month. Rest we buy ourselves. And during the time when the N95 mask was not easily available in the market, we used the mask. And goggles, face shields, we use them. And gown for the OT, we get new gowns, and for minor portion also we use we reuse the gowns to the laundry of the hospital laundry. And regarding administrative help, administration is helpful, but we are not getting adequate masks as well. It's the same situation in every hospital. And regarding the income, being a government hospital, our government salary is not cut, but the income, overall income, has been affected definitely from the clinic income. And in this time, the clinic running cost has been costly increased because we have to use all the masks, all the sanitizers, all the disinfectants, and we have to reduce the patient numbers as well. And I think we have to change the practice according to disease epidemiology. Right now, there are 79 cases in our western part and 205 cases in our area. And if case increase, I think we might have to reconsider use full protective gear even in this weather. We have to close the OPD again and restarting elective OT. I'm not sure of when, but I think it's not a good idea to restart elective OT when the cases are increasing. When the new cases decrease, or when the active cases start declining, then it will be a better idea when we can restart gradually. Thank you.
So thank you, Dr. Ashok. So, Dr. Ashok, I have one question for you. So, how do you re-sterilize your endoscope, just like the surgical scope or rigid endoscope after you use it every time?
I think in IPA guidelines, 2.45% brutal solution.
Okay.
Or 10 minutes is effective for coronavirus as well. Okay. We give for 20 minutes at least we maintain the period of 20 minutes between the endoscopies, and even after that, I wipe the endoscope with isopropyl alcohol 75% for 20 seconds. Okay. And for the rigid endoscopic system, we need to have 2-3 rigid endoscopes so that we can change them automatically and dip in 2.45%.
Okay. So thank you, Dr. Ashok. Thank you for sharing. So I'd like to request Dr. Brihaspati to share his experience.
This is our hospital. This is the Gandaki Medical College. I'm working here. Is and also MBBS program. I have a other hospital too in private hospital working in the city. This is the big city area in Pokhara. And side by there is a bus park whole thing. Roadside, if you see, this population is it is decreased in any area of the world. This is the parking area. Just we put there, and we walk from here to inside the hospital. And this is the ticket counter, as you see. Yes, we try to put the thing cover of the plastic. Still, we are trying to get out patient from outside. Initially, 2 weeks, as already mentioned by Dheeraj, and so we did same thing. Almost all things is shut down. Everybody appear of the disease, but slowly we know what is the disease. We personally or many meeting, we understand what is the corona, and then yes, we have to go with corona. There is no excuse. Yes, so yes, we have to do something like that. Then yes, we know we have multiple meeting with the government, for this government, and in medical college too. Yes, how to run. I emphasize because I'm the head of department. I emphasize every time we have more susceptible thing like we dental people and chest physician. These are more vulnerable than other. Yes, everybody is infected. So we try to change the thing, something at least before we start the next. Here also, like Ashok said, we try to put the government to put isolation hospital like that, Corona Special Hospital. But here also they plan to become Corona Special Hospital, Western Region Hospital, which is the meat of the city. Yes, from our part we refuse that kind of. But it's not possible now. Almost now today news that they're almost back and nobody can go into the hospital. Then what? The next hospital is Manipal or our. Okay, as GMC is nearby, and after feeling 10 patient in the Ocean Region Hospital, what they suggest that you have to, after 10, there is only 10 bed for the corona, all patients to be shifted to Gandaki Medical College. Then that is the news, and then we prepare like that, but it is not like big hospital here, because this in mid town city. What we try to do is we initially starting wash hand, social distancing, but people, I feel really that it is like bond. Okay, Nepal पहिला बन्द भएछ, like that they are thinking like it is bond after opening in the after 5-6 p.m. Every people coming in the city. Then we first to the local government, like I am in the here in the city, so I told some local guide, local means Oda the chair like that. Some word, try to further and tell them please announce and not to come in the roadside. Then that happened, and personally we talk put it in Ramnagar and nearby this and that, and that is strictly followed, because they are not only a hospital, the emergency bed, put some distance between the college. That is the initial day. After government announced that now to start the hospital. This the distance. See, there's some doctor here and sister in the emergency waiting room, but people not aware thing. Okay, yes, we whoever enter in the hospital should be applied masks, that is followed, but distance is not that much maintained, not aware that much. I'm feeling this that way, and it is a pharmacy area in the medical college. See, we make the red marking here. Uh, and one should be go from after one buy some medicine, then other should be go there, but see the people and not following the rule. Okay, this that is the some forum. I feel this is the fever clinic. Every one doctor initially say one doctor should be stay in the hospital for the fever clinic, like one team. They scrutinize the patient. Fever clinic continue to run here in the hospital. That's coming from the government too. So we do the same thing by senior, junior, waiver, all the level. After passing screening from there, if physician think it need to be tested for the corona, then should be sent to government hospital. Otherwise, they shifted to the emergency like that. We maintain. We then tried social distancing here. See the ladies with 1 to entry. Initially, patient go out OPD. I see, but now here there is a room. They have waiting for the to go the checkup inside. And we try to meet here door. This one after that another. Then the doctor 3 passes. Okay, like that. See next station here. See the sisters here. She can again check. Especially my department, I started doing the fever temperature checkup initial day when it started in the spread in the Wuhan. In my department, this is the outside picture. This is the next step. Sister which wearing the face mask and recording all the detail of the patient. This is our OPD here. You can see this is nearby MS room, gyne, ENT, endoscopy, all that. But here they have to check. Initially, it is inside here. Okay, I can show the some video, but here only one by one. Like I think we have to check like airport. So we design like that. So patients should be crossed here. Everybody should be checked here, not go inside. So infection should be less. Then next station is here. Initially here there is around 5 chair to waiting room, but I remove from here and keep outside here. This is the waiting area. We try to maintain waiting. There is a red marking here, one patient to other patient distance on the waiting room area. But here what happens is, if this area is full, no patient will enter from the this station. Okay, that should be maintained by the sister or attendant. This is the initial where patients should wait for the, but now it almost there nothing. If you see this video, patient is waiting here. One, see, this is my department here. Almost here, one patient there. We are doctor there sitting. Initially, one room for the one patient. We have a small room here. Not, but here we design change. One doctor here, intern or resident, a consultant, myself here. Patients should talk like that. I think we should examine from the back side so that, and should be marks should be wear. I examine the back, if attending examination like that. Here, Dr. Tulika here in my department, and me myself, we make like 2 table. We also social distance maintain in the chair also as far as possible. Other like same here. I prefer doing endoscopy initially in clinic. I do like without screening, but now as a endoscopic, I start to see screen in also clinic too. Okay, you have to see the clinic, not patient there. And my this attendant also applying face seal. These are the things. Yes, surgery we initially almost locked down, but yes, foreign body, some emergency surgery we did. Yes, what we try to do is then later on there is a RDT. Every cases we, if there is a GA case or local case in the operation theatre, we did the RDT. Later on we know the RDT that not sensitive. Then PCR started to do every cases, but after PCR they should admit it in the hospital. Again, it's very difficult to do PCR. So what we plan is PCR day prior to admission. After PCR, patient to inside the hospital for the surgery. Last 2 weeks running like that. This is we did major surgery here. This neck dissection, facial masks with our team. After knowing the what is the corona, almost now it's still trying. Okay, what good for us and how to protect family, how to protect other stuff like that. Everybody should wear masks. Surgeons should, but laryngeal surgery, as Yogesh show us, we are not doing laryngeal surgery. Yes, tonsillectomy also by this way I apply full PPE. Yes, hospital supply it's like that. That was not they are given some 1 PPE, but confirmed case is very difficult in our setup because we have to send the other hospital. Pokhara Academy of Health Science, there again issue come is PCR testing. Okay, I slowly written the one document that every case we go elective surgery more than any, and if doctor want PCR should be tested, but it's so difficult and patient is waiting list is there now. It's difficult, and this patient we are waiting the PCR for last 1 week. It's so difficult. Then by RDT we did the surgery. Yes, here also think patients should wear glove in the wear masks. Our audiologists also wear face shield masks, and there is a AC should be run like that. These are the things salary wise, and they provide the salary for child. Till now we are not getting the Baisak. Let's see, but there is no caught up from the hospital. Private hospital, if you talk, I'm at the major working at the major surgical hospital. Almost I did 1 2 surgery by all the thing almost shut down. Okay, economic okay is bad. But another thing happened in my life. If you see my picture now, my father is lost right the back, not due to heart attack. Means my anterior wall infection. This is happened in the half an hour. I can't say. Okay, that is the thing happened to me. Thank you, Yogesh. This is multiple talk with Yogesh, and he encouraged me to talk so that you can also this loss you can.
Thank you, Dr. Brihaspati. Thank you for giving this your time in this difficult situation. We appreciate it.
Okay, and just one. I can take. Otherwise, there is so many people waiting for how daytime. I am not able to meeting. My friend is coming here in the home. Can you just give me? I can out from the today meeting and
Sure.
Thank you, all of you, all kind.
Please take care of yourself and your family, sir. So now I'd like to request Dr. Rajiv from Virat Medical College to share his experience. Dr. Rajiv.
So namaste and very good evening. I am Dr. Rajiv and I work in Virat Medical College, that is in the eastern part of Nepal. So I'll rather talk about my experience and how we work during this global pandemic of Corona. So initially we stopped all our regular OPD services and elective services, but we kept on continuing the emergency cases. And it was only after a period of a month we started to resume our OPD services, but that was during a limited period of time, that is like 2 hours in the morning. So when we talk about what were the emergency services during the lockdown, it was foreign body removal from the ear and the nose in the children, epistaxis, foreign body esophagus. We have to go for esophagoscopy, addressing a case of physical assault and neck trauma, neck exploration, and then the emergency tracheostomy. So I'm not going to talk much about how we screen the patient in an OPD or when the patient enters our hospital. I'll just show you a small video clip how we started the social distancing in our OPD area. So this is our OPD area where the OPD attendant manages to keep the patient in a safe distance and ask the patient to wear the surgical mask. So the next video I'll be showing you the use of headset which we designed locally. So I'm not talking about the donning or of the PP. It is like the surgical gown over which we use a plastic apron with the double gloves and then the double mask with a surgical cap. So this is a cap which we designed here. So this is a cap with a velcro all around it, and in front of which we apply a plastic sheet. And in the front it has a transparent plastic, so which we can examine the patient and go for our OPD. So this is how we get ourselves ready. So this is a waterproof plastic from the head to the upper chest. One of the disadvantages of this plastic gown was we live in Viratnagar and the climate is too hot and humid, and if we wear it for a certain like half an hour, we become too much of sweaty. So nowadays we have switched over our head and face shield to our face shield. So this is how we use our face shield. So we have a double mask with the gloves. So this is a using of face shield. We have goggles and then the face shield with the surgical cap. And then the patient is ready to see for OPD. On the next slide, next video, it is a short video. I'm going to show you how the patient gets to enter our OPD. When the patient comes to the OPD assistant, just outside the OPD gate, he sanitizes the patient with the sanitizer, and he doesn't allow the patient to touch the handle or the gate. When the patient enters the OPD, he sits on the examination table, and you can see there is a plastic apron, plastic partition between the physician and then the subject. So we don't come in direct contact with the patient. Now talking about the syringing, most of the time we have been avoided, but only when there was a case of periphery earache with the impacted earwax, we have to go for syringing, and that too we do it with proper precaution. Together, even our OPD attendant is like fully geared up from the top to the bottom. He has a waterproof gown with a face shield and then the KN95 with a boot. We have slightly modified our NPL rather than going for our conventional nasal endoscopy. We have been using bronchoscope. Let's do a short video. So here, so this is a head hook that we got from our NSU department. There is a vent, there is an opening, a cord slit that comes over the patient neck area, and after the use of bronchoscope rather than the conventional nasal endoscope, nasopharyngeal laryngoscope. The advantage is that the lumen of the bronchoscope is a bit thicker than that of the nasal endoscope, and we don't go from the nasal route, we go from the oral route. So it will take only 10 seconds to examine the larynx. So we place this head hook over the patient face area, and we stand behind the patient. That too, we do it in the sitting position, sleeping position. The patient is made to lie on a bed, and then we stand behind the patient. And with a proper mouth gag, the patient there's a mouth gag, and we do not spray the patient. We use a 50% viscous diluent, ask the patient to gargle, and then we perform this nasopharyngeal laryngoscope. And that too, we perform only one to two cases every day after the scope gets properly sanitized. So this procedure takes hardly 15 seconds if you go through our oral route. So one modification we have done in diagnostic nasal endoscopy, there was a patient who came from Dhanpatra and he was complaining of leaks in his nostril. We are unable to see it with our torchlight, so we had to go for diagnostic nasal endoscopy. So one modification, what we did is we made a small dent in the middle, and through which we inserted the scope into the patient nostril, and we got to examine the patient nostril. And the status of the audiometry is most of the time we have been avoiding but whenever we suspect case of sudden sensorineural hearing loss, we go for audiogram with the necessary precaution. So emergency services in the Virat Medical College was conducted since the period of lockdown with no referral, and these were the medical cases that we performed during the lockdown period. Management stresses foreign body removal in the treatment diseases for foreign body status, and we got a lot of cases of physical assault during this global pandemic. Physical assault, drawn from a neck, and then even stab injury. We had to go for neck exploration, and then the emergency tracheostomy for straddling malignant cases. So I have there is a discussion of the case. Even there was a case from an epidemic area of Lahan, a 7-month-old child with a foreign body in his neck. We could not wait for RTT or PCR, taking the risk and benefit of the patient. We had to go for surgery, taking necessary precautions from both the anesthesia and the surgical side. So this was the limitation of our surgery, because we could not go RTT or PCR. Support from the hospital is like we get necessary PPE or surgical mask and ENT 95 from the hospital, and then the sanitizer. There has been sort of cut down in salary. So now we are planning to prioritize our elective surgery once we get PCR in our hospital. We are very soon going to start PCR facility here. Right now we do have RDT. Until then, we do not have any plan to conduct elective surgery. My take-home message from our experience is that we should know the severity of the disease, and we should take our actions precisely and try to take minimum exposure. Most importantly, what I want to tell is we should not leave or refer any emergency cases thinking if not us, other will go for the exposure. Thank you. This was my. This is what we do here in Virat Medical College.
Thank you, Dr. Rajiv. Thank you. A lot of the people has given a very nice thumbs up to you for a lot of new things that you have been doing. So now I'll request Dr. Bikram to share his experience. Dr. Bikram.
Good evening, everyone. So I'm sharing my experience of working in the Dang district, province number 5. And you've heard about the news that yesterday our 4 health workers, including one hospital director and 3 nursing staff, they have found positive, COVID positive. And we are very in difficult situation now. So myself, I'm also in quarantine, as my PCR report came today is negative, but I think I should be in the quarantine for around 1 week. So coming to the services that we were providing during lockdown was regular emergency services. As the patients were few, only 10 to 15 patients per day. Actually, patient would have been 60 to 70% patients per day. So patients are few, but emergency services, all the emergency services we provided during lockdown period, and all the eligible engineering procedures like endoscopy procedures and elective surgeries that we have postponed. So image services that were provided mostly was the foreign bodies of all respiratory tract like ear, nose, throat, and mostly the patients were child. So basically they have their school is closed, so they are inserting something in the ear, nose, throat, and also fish bones also, and the incision drainage for the superficial and the deep neck spaces, and staxis, also the loss of facial traumas. And one child from the hilly area, Rolpa, they came. This was an interesting case. They came. She fell from the tree, and there was a bamboo stick. She was lucky enough that it was just lateral to the cavity. So I think we have saved life during this lockdown. And about restarting our OPD services was challenging. Before this COVID era, our clinic would have been there was so lots of patients, around 70-80 patients per day, and this was so challenging. So motivation, what we did is we have restricted the number of patients, and all patients were asked, encouraged to wear facial masks. And more important thing about the modification was a ventilation problem. Before this, all the room used to be airtight, full-blown AC was there. So for now, what we're doing is we have opened all these doors and woundows, so there will be enough ventilation. And for this OPD block also, initially it would have been all the door would have been closed, and we opened all the door, and the AC will be running, and a fan is there, and whole this block is well ventilated. And the fan and the AC, what it does is they use as a defogging also. It prevents fogging of this face shield also. And all the this endoscopic this otological procedures I do in the we started doing auto endoscopy only. So the otoscope is obsolete now for the time period. So I'm using endoscope only. So for all the foreign bodies that we're using endoscopes for the diagnostic purposes also, and for the therapeutic purposes. So we'll be using endoscope, so that there'll be a quite distance between the doctor and the patient. Another thing is we have to protect ourselves also and our staff also. So I'll be in the full-blown PPE, and also all the staffs they wear N95 masks and along with the face shield. And the NPL I have started with modification. So what I do is I made a small hole in the nose. 2 masks the patient will be wearing. One mask will cover the mouth part, and the other one is the nose. So small bed will be there. And this way, and what I do is I don't use Jalapeno spray nowadays, because this spray most of the patients they'll be irritated and they'll be coughing. So to prevent that, I'm not using that. And the patient they are fine. So my assistant is also using a sort of PPE. So in this way, I modified the NPL. And for now, our auditory services has been closed. Main problem is the ventilation. So how to do a ventilation. So, and about the hospital administration is I think as in the whole the country, and our hospital administration is partially supportive. I think PPE, all the sort of things we have to do. We have to buy from our own pocket. And the impact of economy is as all economy has been drastically impacted there is in the economy. That's our economy is also hampered. Government salary we are regularly getting, but all EHS and the private clinic is hampered a lot. There are few patients, and we are not doing the elective surgeries, and most of the endoscopic procedure also. So impact economy has been I think is hampered. And plan for the elective surgery is I don't know, maybe after a pandemic, control of the pandemic, if we don't see no new cases, and if the PCR is widely available before all surgeries, and also we are waiting for the SOL decision by the SOL about the protocol of opening our elective surgeries. Thank you very much.
Thank you, Dr. Bikram. Thank you. So I just have a small query. So you prepare all your endoscope. Okay, so once you see your OPD, then after the OPD is done, so you collect your patient for endoscopy and do an endoscopy, because you have to put your PPE, and you have to prepare yourself. So you do
No, for
all.
I have no, I use PP for C patient also.
No, no.
Full body PC from the initial beginning
So
also.
you do use a PPE.
Yes,
Okay, so
sir.
you use a PPE, you see your patient, and if that patient has to go endoscopy, has to do endoscopy, so you do endoscopy using the same PPE, and again come back to see another patient using the same PPE. Is that so?
Same PP, yes, same PP.
Okay,
I use the spray, the speed spray. I
okay,
put same PP.
okay, okay. So
What to
thank
do?
you, Dr. Bikram.
Well,
Thank you so much for
thank you. Then.
sharing. So, Dr. Mukesh, can you share your experience in Birgans, which is nowadays being a hot spot?
Good evening, everyone. Uh, I'm Dr. Mukesh Marsa, working at National Medical College, Birgan, Province 2. As other speaker said, we do have to stop our services, but that was not due to our wish. That was forcibly closed by the government bodies, and they closed even emergency for 3 days in last week of May. Or beside that, we have continuously serving the people throughout the corona pandemic. We still give emergency services, uh, mostly the cases of epistaxis, foreign bodies, and trauma. We are doing surgeries in cases of trauma and foreign body, and for epistaxis we do emergency procedure like packing and cautery, etc. thing. For precaution, what we use is we have PPE provided, not standard PPE, but a PPE provided by college itself, and our local NMA has also provided us a set of PPE, also have provided face shield, but all those things are reused every day, because we have total only 2 sets. After the 3 days of complete shutdown, we restarted OPD, but we didn't change much. What we do is we allow the patient to enter only inside the chamber, examination chamber, without companion, and we maintain distance while taking history. Some examination can't be done by maintaining distance, so we do examine, but we do only focused examination. If complaint is for of ear, we examine only ear. We do not go for neck and throat like that. And again, we have only PPE with face shield that we wear, as well as our staff, other staffs in the OPD also wear the same set, PPE with face shield. This is the our OPD setup. While taking history, we take distance, but for examination, we don't use endoscope here for examination of the ear, because our endoscope is in another building, and we cannot go every time because we have continuous large load of patient in our setup. Even in the time of corona, we are seeing 30-40 patients daily. So that's not possible. One reason, because its endoscope is in the other building, and we have many patients. We have to miss all those in time. So we are still using otoscope, but we try to avoid the direct patient contact with the patient. NPL also we are doing sometimes, but only in needed cases, because we try to avoid in habitual dysphonia or LPR cases. But when we suspect mass, or there is dysphagia, or suspected foreign body, we do it. Uh, we do with precautionary PPE and face shield, and try to avoid direct face on, but we don't have difference in any setup. This was a case which we did with a cyst in the hypopharynx. Her neck was very much tender, so we were hesitant to do MPL, but since it was tender, we did it. This is our surgery room setup. Our one of the staff wearing PPE, then gown over it before going for surgery. So we do emergency surgery of all kind, including the repair of uh, tongue injury or peritoneal abscess drainage, uh, but with precaution. But there is no gross change in our setup. Yes, our management has been supportive, very much supportive. They have provided us PPE, face shield, 3 N95 masks, uh, but that all for a single time only. And when everywhere there is cut off in salary, we don't have any issue with that. And they are also willing to change setup as required, and they have asked us for any modification if we want. And we are not doing routinely elective surgery, but for emergency surgery, what we do is we do RDT. That too is provided free of cost to the patient. For elective, we will start soon when we plan some modification in the OT setup. Our audiology service is also running continuously with uh, whenever a patient comes into our institute, what we ask them to wear mask, wear gloves. We don't have active fever clinic here. We have fever clinic, but that is just for name. What is done there is they just screen temperature with infrared thermometer, and they send the patient in, and there is just maintenance of distance while they book the ticket, but after that they gather again because there lots of patients are here, so that distance is not possible. Distancing is not possible here because we have a big crowd inside our hospital. So our all setups are running except for routine surgery, which we will start soon.
So, Dr. Mukesh, I have one question for you. So,
Yes.
since Birgans is a very hot place, and we have also visited your OPDs, so how convenient for you to wear a PPE and see the patient?
Sir, initially, what we do, we have only two sets of PPE for each people. The one provided by the college, other by the local NME. So, on initial days, we used to wear it daily, but what we use the PPE set given by the college is not reusable for a longer time. So, I we all have only one functional set of PPE. Now, when we examine patient from morning to evening, it's become very difficult to wear full time because we have fan that cannot uh, lower down the our heat. So we get drenched in the sweat when we come
So
out
my,
of the.
so my question was to Dr. Mukesh was that because wearing PPE and having a lot of sweats in yourself, and we are compromising a lot of things on that. So
Okay,
instead of that, wearing a N95
I
mask,
got your question.
proper this air seal and a simple this like gown, maybe I think
As a super spreader.
true. True, because we always compromise somewhere because having that PPE and in beer guns where the temperature is roughly about 50
Sir, what is though we are able to protect ourselves even by drenching ourselves in the sweat, but using single PP and doing all procedure, although we advise every patient to wear mask, there is chance of spread of disease from myself to other patient. If somebody previous patient has uh, transmitted aerosol over my dress,
true,
other patient. That's why we advise every patient to wear gloves as well
okay.
beside
Gloves also.
mask.
So, but a lot of the study has shown that gloves makes people means much more. They think that wearing a gloves they are protected, but they are much more super spreader. So nowadays, Nepal Medical Council and I think a lot of the organization they are preventing a local means a general public not to wear a gloves, but to wear a nice mask, and only the gloves are for a healthcare worker. So thank you, Dr. Mukesh, for sharing your views. Now, I'd like to request Dr. Krishna Kola, the head of the Department of Manipal Hospital, to share his views, sir.
So good evening, all of the presenters and all the other heroes who are there, and Dr. Suresh and SOL. Special thank you for you for providing me a chance to present my views and experiences regarding ENT practices in the periphery. So most of the things have already been told. So I'll just go to OPD services. As you know, due to COVID COVID infection or COVID pandemic, number of patients themselves have decreased by 1 after 2/3. So we have just seen around, we are seeing 15-20 patients per day. So this already tells that there is distancing by the patient themselves. So what we do in our setup is 5 patients enter the OPD waiting room at one time. So that is patient restriction, only 5 patients. Visitors also are also restricted to the minimum. At least sometimes when there is child, then we will ask the visitor to come in. Otherwise, we will not let the visitors come inside the examination room. So mask and gloves are made compulsory for the patients while entering the OPD. This is by hospital. This is not by ourselves. So hospital has made gloves and masks compulsory for the patients. And PPE, N95 face mask and face shield are worn by the clinicians, which is provided by the hospital. So they are good enough for us to provide these things. And social distancing we maintain with the patients. And we restrict nose and throat examination to the minimum. So if the patient tells, then like symptom-wise, we will examine the nose and throat. So duration of consultation also been restricted. Preliminary history will be taken by the interns outside. Then we'll just see the patients. So this is our OPD reception that you can see here. OPD reception, there is a circle. So patient will stand here and sister will just register the patient's registration. Then this is the OPD. I'm here examining the patient. See the old lady with the submandibular adenitis. She's wearing the mask. In the ward rounds also, we take ward round from slightly far away, around 1 meter distance. So these are the ward rounds, OPD and OPD reception in our setup. So other general measures in the OPD are, we provide good ventilation in the examination room. There is no towel in the chair. So this is the back door of the room. This is the back door, which is seen that there is plenty of air coming from the back door as well as from the front door and the fan and from the window. So this is the window and that is the back door, and this is the OPD setup here without towels. So doors knobs are sanitized every 25 to 30 minutes by the spray, and patients are requested not to touch the door and door knobs. So they are requested not to touch them. And doctor using a pen only in the OPD and no other metallic substances. So simply one pen and patient's, there's a patient file here, patient's OPD file. And you can see this is the sanitizer here. We don't use the xylogen spray nowadays. So headlight is mostly on during the time of consultation. So the thing is we have to see with the headlight. So if we keep on and off for the headlight, then it might be problematic. So just most of the times it is on, but when you do endoscopy, we put off the headlight. Then oral examination has been done with oral spatula. The problem with our patients are some patients are not satisfied. They want their mouth oral cavity to be seen, so we use oral spatula, which is disposable most of the times. So OT and emergency services during the lockdown period, rigid esophagoscopy for anybody removed from the ear and nose were all done. Incision and drainage of the abscess were done, and MRM for plain abscess secondary to onychoitis media squamous are performed. 2 cases were performed, and biopsy for malignant nasal mass was also performed. So we have almost performed all the ear, nose, and throat cases except direct laryngoscopy and biopsy and tracheostomy when the patient did not turn up. Regarding the emergency, we have continuously doing the emergency and OTs and OPDs. For the initial 15-20 days, OPD was closed. Then OPD was run with the half staff, full time, half time from 9 to 12 o'clock for 15-20 days. And for last 15 days, we are continuously running full time running our OPDs. So for last 10 days, we had run with the half manpower, 50%. From 1st of Asar, our hospital is totally in run. So fully functional from 1st Asar. Especially for endoscopic flexible nasopharyngeal laryngoscopy, the counseling for patients were very challenging. So most of the patients, they were incest, they were cancer phobic and having foreign body sensation for a long time, many months. So they wanted at least some endoscopic procedures that they wanted to be sure that they didn't have any disease. So sometimes we have to do negative counseling also regarding maximal viral load in the nose and nasopharynx should be there. So it is good not to have endoscopy done. But for those patients who underwent endoscopy, there are positive findings also. We had found 3 varicular cysts for those patients who had foreign body sensation and throat pain, and 2 laryngeal growths were seen during the procedure. So for patients negative finding, we used to give medications for slightly prolonged period to avoid unnecessary frequent follow-up. As you know, these patients would keep on coming time by time. So our protocol was to give at least medicines for 1 month, anti-gastritis medicines. So 1 month, so they will come after 1 month only to follow up. endoscopic nasopharyngoscopy was performed with caution. We used flexible nasopharyngoscopy. Initially, we used to use patients in the hair seal with mineral water bottle case. I'll tell you what is that. And later on, we used a small hole in the plastic curtain. So these are the negative things that we used to do for the patient's negative counseling part. So just patient, they have habit of pulling the chair and coming nearby to the patient. So just we used to tell that you used to just counsel them regarding don't come near the patient, near the doctor, and doctor also might transmit your disease. So this is endoscopy of pyloric progress. Like we didn't use a gland spray as has already been told. So what we devised was this is the plastic curtain which separates the patient from doctor in the OPD. So especially in the clinic. So this is the screen and this is the hole in this plastic shield from where the endoscope would be inserted to the patient's nose. So this was the new technique. So as the endoscopic procedure would have been finished, then you would sterilize the endoscope. Okay, and this plastic shield also will be sterilized. Screen will be sprayed by the sterilizer spray. And this is the plastic shield. I think you will be able to see or not, no idea. But this is the plastic vault. This is a mineral water case. So this is easy to clean also because easy to sanitize also. So spray can be used, or we use the spray 70% alcohol spray, 70% alcohol spray to sterilize it. And this is the endoscopic procedure being done. The patient is here. The patient is here, and the doctor is inside. Patient is out. So same thing, doctor is inside and patient is out. In this case, patient has tried to come inside, and this is the screen. The distance has been maintained. So this is the visitor who is looks. Sometimes they want to look at the endoscopy, the screen, and that will be seen from outside only, not from inside. It will be separated from the examination part. So this is same thing, and this is the plastic. This is the mineral water plastic vault. So this has two openings. So one opening is here, and one is downwards. So the lower opening is slightly smaller. So patient, there is a small hole here in the nose was made in the nasal area. The endoscope was inserted, and there was very less chance of aerosol generation during this thing. And this, after finishing the procedure, this plastic would have been sterilized, and along with the endoscope also in 2% side X. Can see the flap hole to pass the scope. Small hole that is flap, so that can be closed in other time. Again, same thing, plastic curtain between the patient and the doctor, which is sanitized with sanitizer spray every hourly or whenever needed. When the patient just touches here, then we used to sterilize it. I'll show the sterilization procedure later on. This is also flap hole to examine flap hole. So this is, I think you can see, this is the flap which is going up, and I have just taped it here. The tape can be pulled down and it can be closed. So when you take the history, when you are taking the history, this can be closed partly. And when you are looking at the patient, this can be opened, and you can see with the help of headlight. This is the headlight. I think it is visualized. So this is the spray, which is used to spray the plastic sheet from outside, if needed from inside also. Either after each procedure or when you deem necessary, when there is some like when the patient has touched this, then we use to spray like this with the 70% alcohol. This is the sanitization of plastic curtain. So regarding audiometry services, our audiologist uses N95 face mask, gown, and gloves, and the audiology procedure is being done continuously. Hospital administration has been supportive to us that they have provided adequate amount of gowns, PPEs if required, the N95 face mask and gloves. In fever clinic, in the main entry has been established in the hospital's main entry, and all the patients with fever will be sent to emergency or emergency. Then we are not want to see any cases with fever. So hand sanitizer made available at the entry point. This is the hand sanitizer, and this is the tray. This is the case. Face masks and gloves have been made compulsory for patients to enter the hospital. This is by hospital, and they sell it. They sell face mask and gloves to the patients at this in a reasonable price, probably. Regarding RT-PCR, all of our compulsory. They are compulsory before elective surgery. They have been made compulsory before elective surgery for last 15 days. So we don't operate on elective patients without RT-PCRs. If RT-PCR comes negative, then only we do surgery for the elective patients. And for emergency patients, swab is collected from the OT from the operation theatre itself. So we should be careful in case of emergency patients. But as you know, the cases of emergency patients have cut down nowadays. They have reduced. So we have not done emergency cases for last 10-15 days. The next thing is plan for elective surgery. We have already started our elective surgery with RT-PCR test when the patient, like when the PCR report comes negative, then we do surgery for the patient. We have been 3 or 4 elective surgery. So considering to postpone routine surgery has still been a practice, but we don't know the patients, as already told, they come from far away. Supposing that they will operate, doctors will operate on them. So still it has been a problem, but some patients, they are still understanding. They have told that they'll come after some time when the pandemic decreases slightly. And the very difficult question is how long to wait. So therefore we have started doing our elective surgeries, but with strong precautions and after negative PCR report only. So almost last impact of COVID-19 on police regarding income and it's us regarding salary. Obviously, this is a great issue and has got a great impact on economic all over the world. So more than 50% reduction in the hospital income has been there due to a decreased number of patients and procedures and increased daily expenses in terms of PPEs. There is extra cost in sanitization, training of staffs, investment of PCR machine. It has been described the salary issues are always there as we are working in a private institution. So hope this can be managed by dialogue with the administration. And just to disclose that we are going to talk regarding that tomorrow with the administration. So thank you so much, Dr. Yogesh and team, and SOL Nepal for providing me a chance.
So we'd like to thank you, Dr. Krishna, for sharing your experience. It was so wonderful seeing you having all those innovations and all. So how many endoscopes do you do every day? If you have to
usually that depends, but we usually do 2 to 3 endoscopies per day. So first, like when the last patient in the OPD comes, suppose it comes today, then we'll call him tomorrow in the first sitting. So that after that I sterilize the endoscope for around 20-25 minutes. Then we can just give 20-25 minutes for the patients for doing endoscopy. So I think we sometimes do 3 or 4, but sometimes 1 or 2 like that. But we are almost doing endoscopy per day, 1 or 2 per day.
Thank you, Dr. Krishna. So there was one suggestion to Dr. Mukesh from a participant, especially from Professor Bimal Sinha. So instead of asking the patient to wear your gloves, we can ask the patient to wash their hand. It will be much more effective because the patient may have a false perception of getting protected by wearing gloves, but they could be a spreader of the disease. So washing the hand could be a better modalities than wearing a gloves. So now I'll like to request Dr. Tilak to share his experience.
Greetings to all of the participants and the panelists. I am Dr. Tilak Rimbu, now working in the Chitwan Medical College, Chitwan. The lockdown has done everything new for all of us. So on Chaitre 11, the OPD was stopped, as all of you know, abruptly and without any preparation or any knowledge, or it was all confusion. It was almost anxious. What do you say? It was all confusion. It was confusion. Personally, I was very much confused and I didn't know what to do as a HOD. And there was a meeting in the medical college. So what are we going to do next? Nobody knew. But as a medical college, the emergency was continued as we are 4 of faculties are present in this medical college. So we did our emergency call on the on-call basis. But the patient was very much minimal. In that period, we did some wound repair and incision drainage, some foreign body removal cases. But how to protect ourselves and the proper guideline was not there at the initial phase. We turned to SOL a few weeks back. SOL developed precautions guidelines and we tried to follow that one. Again, meeting with the administration, the OPD was reopened on almost on the first week of Baishak. But still, we didn't know what to do, and lots of things was going regarding the PPE. And personally, I have not seen the PPE, and what the PPE was there initially. I did gone through the Google, but fortunately I did not. We did not have that kind of PPE to protect ourselves, and the patients was very few due to the lockdown. Hope that it was due to the lockdown, and we did our duty rotations on the 3 days basis on the 4th day, and staffs were almost 50 to 60% of staff was cut and was put in the on the leave. Regarding the OPD modifications, after getting the different suggestions and the guidelines, and, and apart from that, and from guidance from the health ministry, the fever clinic was started, and all the initially all the cases of fever and with suspicious history was referred to fever clinic. And at the main gate of the medical college, one of the staff, one or two staff stood there with the laser gun for the temperature, and the sanitization using sanitizer was used. So, and then the patient used to go for the OPD ticket and then go to the respective. Regarding the ENT OPD, the patient was short history was taken. Initially, we did had interns. So initial by using the simple max, we the patient was history was taken regarding the past contact history, travel history, and fever or some kind of airway or shortness of breath. Then the patient was asked for the other examination, what the symptoms the patient had to come for the ENT. And we usually ask the patients to those who have contact us by the phone or mail or Viber or some other messenger to come to the hospital as less as possible due to this pandemic. Uh, Initially, we did not have the PPE. Well, we only used the masks, the gloves, locally made or the hospital made plastic key was there for the examinations. In the next slide, this one in the next slide. Yeah, this was locally made by the medical college. The face shield, the masks, the gloves are used to examine the patients. That and we asked other departments to have a less interdepartmental referral. So minimal procedures was done, and we stopped audiogram. No NPL was done for the almost 1.5 months. But then afterward, we did some NPL cases for the fees of for the examinations. The patients also of some kind of severe pain. We did that with the precautions. For follow-up cases, due to the other previous surgery case was entertained, and from now the gist of this month, for the gist, the first week the gist, we did the doing the 7-day alternate duty rotations for faculties, and the patient the flow has increased than the last 2 months, but still the NPL is limited. Audiogram was stopped till now, but we started on the 1st of Asa, and few cases of incision drainage of neck abscess and other surgery, traumatic surgery repair was done. Regarding the salary, everyone knows is a open secret. There was almost the salary has been cut from the first day of the lockdown, and the remaining leaves has been cut to give the proper salary and any elective surgery. And we had a meeting regarding the PCR test. If it gets easily available, and the PCR regarding the PCR test, we'll start the surgery, uh, exempting the aerosols, increasing like we will only the neck surgery and some kind of myoplasty. We are avoiding airway surgeries, tonsillectomies, face for right now. I don't know for how long, but still we are uh, using the universal protections, and during the surgery we are using the viral kit which is available in the pharmacy for the protections. Only the proper PPE has been available for only the, I think, with the ICU staffs. For OPD, the locally made protections and the universal precautions and sanitizations is continued for the patients. This much for me. Thank you.
So thank you, Dr. Tilak, for sharing your experience, and thank you so much. So may I request Dr. Biswa Tulachan from Universal College of Medical Science to share his experience, sir.
Namaste to all of you. I'm Dr. Biswa. Thank you very much to SOL Nepal and Dr. Yogesh to let us share our here. So far we are safe. To let you know, all people, that in our hospital we have 2 inquiry desks, one entry gate and next being in the OPD building entry gate, and also we are supplied we are and the temperature gun in the OPD by the guards with the full protective measure are allowed to enter into the OPD building. Proper social distancing, and also thing like the number of patients low compared to the pre-lockdown period. 15 to 20 patients per day, and all working doctors in our ENT department, and we are. That means we have doctors, like one pool is active, for pool is active, inactive in the sense. So one pool have to, and other pool is safe for 1 week. So the other pool will take care of the patient department. It's like that. Here in the ENT service in the USMS, initial in the lockdown, initiation of the lockdown was following the used to see patients, and they used to come directly via the emergency. The fever clinic was there, and also we have one isolation ward, also one isolation ICU for those suspected in the fever clinic with the proper the isolation ward, and the route ward is also the different. To our convenience, we used to see in our own ENT OPD where the proper, so that to avoid the crowd. Faculty's duty, OPD duty, are kept on rotation, and we are running with the 50-50 idea. Emergency services during lockdown, so mostly it's the and mostly it was in the. So we used to take it out in the OPD with the as far as possible, and the other done with the PPE and other OR, and also And regarding the restarting of the OPD services regarding the it's not much strictly modification. This is like we provide awareness to the patients, like the visitors, and like the temperature being properly taken, and the use of sanitizer. OPD building or into OPD waiting hall, then they have to come one by one, and the accompanying person is not allowed to come within until the patient is outside. Once we see the it's masses, we try to use gloves. We don't use gloves, but what we go to the washing, proper hand washing with the soap, and again we. So that's the daily routine. But we didn't use the gloves. The mask and 95 masks are must to us, and by the hospital. But these days they are not providing only. So regarding the protection measures, we have all mask, protective goggles, body gown in OPD is in our hand, but it's very hot here. Hours we are not using the PPE. So all the think that it's very important. This PPE, then only at that time we are using the PPE. Like in the OR, our JR is using it, but we do have PPE in our hand. They are reluctant to use it as the temperature is very hot here. Just following the simple, like the hand washing, goggles, and the mask. That's all. Mentioned that one patient at a time, and with the at least 1 meter faculty, doctor, and the patient, and trying to follow the non-touch technique as much as possible. Staff in the reservation in the reservation desk, with the proper following of distance, and also she does wear top gloves and the mask. She's always ready with the hand sanitizer. The evidence as the crowd. That is the main thing, and we are let the patients to have the mask on. Necessary masks should be there, and the social on to come up. So is that what we did in the OPD, like this local child who came with the foreign with the goggles, protective goggles, and the mask, removed it in the OPD with. So it came out successfully. Okay, and there was so after each patient, and I wash my hand, and that's my routine. This the NPL, it was man because he came with the complaint of brain aphasia and a little bit of difficulty. So we had to do the NPL on the right BFS, and the right TBC was to the Periphery Cancer Hospital. The biopsy, because it was not in this context, so we put and they will do the further management, as it was a pure case of It's like the routine. And hardly in a week we do like, and we do follow the. So these are doing NPL in the OPD. We do only in the needy patients with the mask after the procedure is off. Patients requiring NPL to the needy patient, the NPL, and who doesn't need, like the case of ALPR, we do. It's not necessary to them. Is we of the disease, like it's not an emergency, like malignant disease, so they get convinced him to come after 1 month or 1.5 months, like that. So regarding the service in our OPD building, but whenever, like in case of post-traumatic hearing loss, where compensation cases of suspecting of sudden sensorineural hearing loss, we to our nearby city where the audiometry do the audiometry. Regarding the emergency charges, yeah, we are doing the emergency charges. The protective measures so far, 2 tracheostomies were done. We went wrong ventilation for the neurosurgical cases, and it was done by our third year JR with the full PP. And 2 foreign body and 1 fish bone in the valvular. 1 fish bone in valvular was removed with. It was all done by our third year JR. Done to the OR, so all the surgery. And yes, we do have we are provided with, but we are reluctant to use it as until it's very much needed. We are not going to use only at the AR or. That's all. Regarding the economic impact, we are getting salary. What the actual salary? The duration is a little bit later, like the 15 to 20 to the pre-lockdown period. But we are reduction. But our duty is regular. In the hospital, we need to do the duties, whatever the. Are getting the full salary. On, I think definitely there is the economic impact. I half by the 50%. Hip surgeries, so far we have not done any like. But in the coming days, as the hospital or in the private setup. We'll start with the elective surgeries following. Thank you again. Okay.
Yes, thank you, Dr. Bisu. Thank you for sharing your experiences, and we are happy to know that you get a salary at least after 15 to 20 days. So it's so nice of you to share your experience. May I request Dr. Sagun to share his slide?
My esteemed panelists, everyone attending today, good evening to you all. I am Dr. Sagun Shrestha, lecturer at Nepalganj Medical College, Kolpur. I would like to thank the Society of Otolaryngology of Nepal, especially Yogesh Dai, for this opportunity to present the scenario of our hospital during this COVID crisis. Now, most of the things have already been covered by now. In fact, frankly speaking, I had a chance to learn a lot of what more we could do further. So I would not like to take much time and just share our story. First of all, I'd like to introduce our department. Our team under Professor Dr. Dumiras Bodle as head of department, we are Dr. Shama Bhandari, myself, and Dr. Sulabh Shrestha as faculties, with residents Dr. Kumar and Dr. Subhash at Kolpur, Dr. Lokran Verma and Dr. Anshu Sharma as faculties in Nepalganj, and Dr. Sana Kidwe as resident. As we all know, the first case in Nepal was diagnosed on 9th of Magh, the first in South Asia. Nothing else happened for a whole 2 months as we went by our daily schedule of routine duty. We hoped and prayed for the best and weren't quite engaging in taking precautions, as you can see. However, it was the diagnosis of the second case that sparked a wave of fear around the country on 10th of Chait, which initiated a lockdown of the whole country the very next day on the 11th. Our OPDs closed as well. During this time, we provided services like ER, Inpatient Department, Fever Clinic. Faculties and residents were posted turn after turn for duty in the fever clinic regardless of their specialties. With very preliminary preparations, inadequate supply of masks and PPEs, lack of proper protocols, and lots of confusion and fear, the fever clinic duty continued. Gradually, we were provided with PPEs of better quality over time. Continuing the ER duty, the following cases were managed according to pre-existing protocols. Interestingly, an increased number of suicidal tendencies was observed. On the 1st of Baisakh, our hospital was declared as one of the level 3 COVID hospitals in the country. PCR testing was started at Perizonal Hospital on 7th of Baisakh, after which the first case in Bankhe was identified on the 18th. 22 new cases were discovered in the next 5 days by extensive tracing of their contacts. During this time, we had already resumed our undergraduate classes online and PG classes as well, maintaining proper social distancing. After lots of talks and meetings, our OPD was scheduled to resume from 29th of Baisakh from 9 a.m. to 1 p.m. initially, which was extended to 3 p.m. later on. We tried to reduce nasal, oral, and laryngoscopic examinations as much as possible so as to reduce the risk of aerosol generation. We tried to avoid risks by using disposable wooden spatulas and first treating the cases symptomatically. We were averaging somewhere between 10 to 20 patients per day wearing protective gears as seen. Patients were required to fill out questionnaire forms outside and then only enter the hospital. The functioning of our OPD can be seen in the video. As seen, all our staffs and doctors on duty wore proper protective gears whilst working. Regarding NPL, during the initial days of lockdown, we had performed about 8 NPLs for various cases admitted in the ER and the ward, wearing gloves and masks only. However, after the identification of the first case in Bankhe, it was stopped. NPL was then performed only for a suspected case of malignancy, wearing surgical masks, visors, and double gloves. For patients of LPR, they were counseled about how us, the doctors, and the patient themselves would be at an unnecessary risk of contamination for their non-fatal condition. Some persisted, and we advised them to follow up after 1 month of medical management first. PTA was resumed alongside our OPD. Our audiologists geared up in PPE for the test, as can be seen in this video. We've performed about 15 emergency surgeries till date, wearing visors, double gloves, and double masks. We had to refer 2 cases of suspected malignancies, a case of foreign body airway and a case of respiratory papilloma. The hospital administration has done well in improving the quality and availability of PPEs to the entire staff. But as always, there is still room for improvement. As for salary, we have received our salary for Chait, and maybe due to the financial constraints posed by the present crisis, the rest has been delayed. Plans for elective surgery. Until this pandemic crisis doesn't settle down and adequate PCR testing is not regularly available, elective surgeries have not been planned in the near future. Recently, on 27th of Jet, the first positive case was operated in our hospital. On 1st of Char, the first death of positive case was reported retrospectively. All of the 81 staffs, including 29 doctors, one of which was our very own resident, have tested negative by PCR testing. Those who came in direct contact are in quarantine. This brings us to today. That was our story. Thank you very much.
Thank you, Dr. Sagan. Thank you for sharing your nice story. So, may I request Dr. Apar? I request Dr. Apar to share his experience.
So, good evening, everyone. So, I'm Apar Pokhrel. I'm working as an assistant professor in College of Medical Science, Chitwan. So, we have 4 faculties in our hospital. Our HOD is Dr. N. Jay Prakash Maya. So, after I am there, and 2 other doctors, Dr. Vikas and Chaya, they are working with me. So, like since the start of lockdown, we have not closed any ENT emergency services. So there is a fever clinic which is set up by our hospital, and ENT people, the residents, they attend the fever clinic every 8th day. So every 8th day is our duty. So like emergency services like epistaxis, foreign body esophagus, neck abscess drainage, foreign body bronchus, tracheostomy we are doing. So emergency tracheostomy we have not done up till now, like prolonged ventilation, like if the patient is on endotracheal tube for more than 10 days, then we have been called to do tracheostomy, and we have done that. So if time permits to do RDT test, we do RDT test before every procedure. But if time doesn't permit, we do post-procedure PCR test. Like we'll admit the patient, we'll send the PCR of that patient and see like whether it is negative or not. So till the PCR test has not come, the patient is kept in an isolation. So we have not also halted our OPD services. So as the flow of patient has reduced, what we do is like at present 3 faculties are working. So 1 faculty with 2 residents, they sit in OPD, and next the other 2 faculties, they are on leave. So we sit in 1 room, and we have made 1 separate room for seeing the patient. And like audiometry facility, it is not there in our hospital. So this is like examination of oral cavity. We use a face shield, use N95 mask, and we examine. Like if the patient is not having any throat problem, we don't say don't examine the throat. But like if it is there, then we have to see the. So NPL-scopy, the procedure is not stopped completely. Like if the patient is from a red zone area, in particular from province, from like Birganj or from Kapilvastu, then we ask the patient, we ask for a PCR test. Otherwise, we do a compulsory RDT before doing NPL-scopy. And for LPR, we are avoiding NPL-scopy. So this is NPL-scopy we are doing. Basically, we make a two masks. And the first, we cover the nose and the oral cavity both. And the below, we make a small hole in the mask through which we can insert the NPL scope through the nasal cavity. And by that we are doing. So this first patient was from Birganj. So he was little bit suspicious case of malignancy. Therefore, we did the NPL scopy. Otherwise, we are avoiding it. Luckily, however, the NPL scopy was normal. So we have not also cancelled any routine OT cases. But what we do is like we admit the patient, we counsel the patient that we need to do a PCR before doing routine OT cases. And the PCR usually report comes around 2 days. So they stay in the hospital, it little bit increases pre-op stay. So if the patient agrees, we are doing. If the patient is not agreeing for that, we are not doing the case. Now the salary issue is like we some faculty have got salary from up till January, some has gone up to February, but like since February we are not getting the salary. We have up to February we are getting the full salary. From March they are telling that there will be 50% reduction, but March salary we have not got up till now. So this is my experience. Thank you.
Dr. Apar, thank you for sharing your experience, and because a lot of the things that you wanted to share, maybe it was conveyed by previous panelists, so you shared, so you short-circuited. So thank you for sharing,
Yes.
Dr. Apar. So thank you, everybody. So I'd like to share a few of my slides and come to a conclusion of today's webinar that we are. So thank you all. So nowadays we are thinking what is a new normal. We are on webinars, we are on everything, and we had adapted our lifestyle with sanitizer, with masks, with washing our hand, and with social distancing, which is obvious. So and we're also adjusted with this. We are doing a webinar with our shirts and ties, but our shirts. So we are adjusted with what is new normal. So and we are also adjusted with this, so we should get adjusted, and we don't know till when, but but by now I think most of us are adjusted to this. So a new normal could be this in school, new normal could be this in canteen, and new normal could be this in marriages, and new normal. So a lot of the people are adjusted ourselves in new normal. So in new normal in gym also, a lot of the people are missing their gym and they are adjusted. So medical professional, as we are healthcare worker, we should live with corona. So now I think we should get adjusted with this corona, and we should live with this corona. So I'd like to thank our panelists who shared their experiences during this COVID-19, and my special thank goes to RPG Life Sciences, who provided us this platform to share our experiences with all our participants. Thank you, RPG Life Sciences, and thank you all for bearing us more than 2 hours with us. Thank you, thank you. If you have any queries, any questions, we can share in our SOL WhatsApp group, so that our queries, because we have seen a lot of innovations, we have seen a lot of new techniques of between each other, so that we can help each other. So if we have any queries, so we can share in our SOL WhatsApp group. So thank you all the panelists, thank you all the participants. Have a wonderful Saturday evening. I think it's night by now, and so see you all.
Thank you, sir.
Thank you, SOL Nepal and RPG Life Sciences.
Good night. Thank you.
Thank you, SOL Nepal. Thank you, Dr. Yogesh. Thank you, RPG Life Sciences.
Thank you all the doctors for attending. Thank you for your kind words.